Hello everyone. For this session, we'll be talking about hemostasis and hemostatic disorders. First, let us define what hemostasis is. This is actually the process by which the body will simultaneously stop bleeding from an injured site or an injury, and at the same time, it will maintain blood in the fluid state. This process occurs within intravascular compartment or within blood vessels, which we all know is lined by endothelium. If this process fails, there are two things that could happen. One end would be hemorrhage. And what is hemorrhage? Hemorrhage is actually the extravasation of blood. There, this is a simple hemorrhage as you can see in the picture, but there are times that there is an excessive hemorrhage leading to the loss of blood and eventually leading to hypovolemia in patients. You don't want a very severe hypovolemic state because patient could die of this. On the other end, thrombosis can happen. No, if you look at uh, this picture on your right, this is actually thrombus formation in the aorta, and on the left side is thrombus formation following cardiac tamponade or hemorrhage into the pericardial space leading to cardiac tamponade, forming this thrombus within the pericardial space. There might be smaller thrombi that can be formed or big thrombus like this that we see in these pictures, and this would actually block the flow of blood and leading to ischemia that will affect the areas or the tissues that are being supplied by the vascular channels. For example, if a coronary artery has a thrombus inside it, it can affect the flow of blood. It will block actually the flow of blood, leading to myocardial infarction. Okay, so physiologic hemostasis has two major parts. One is the cellular component, which is composed of the platelets, the endothelial cells, and to mention as well, part of which are the neutrophils and mononuclear cells. Secondly, there are the plasma proteins, proteins that we see in the coagulation system, the fibrinolytic system, and then the natural anticoagulant system that we have, like the serine protease inhibitors. So, putting it in another way, we have here the platelets. We'll be discussing this and we'll be looking at the coagulation system, the different factors that are found here, the fibrinolytic system, the anticoagulant system, and of course the endothelium that lines the vascular channels. This is a schematic diagram of a blood vessel, and as you can see, pointed here is the endothelium it's composed of endothelial cells. They line the inner aspect of the vascular channel. So if there is vascular injury, the first thing that would happen is vasoconstriction. This usually affect only the arterioles and the capillary smaller blood vessels. And after which there's going to be contact activation of platelets, wherein platelets will be adhering to the wall of the blood vessel. They're gonna release the granules or the content of their granules, and then this will stimulate or call on other platelets to go to the site of injury. There's going to be aggregation that will follow, and also the coagulation pathway is activated in the process. So let's talk about platelets. Platelets are actually the smallest blood cells that we see in the peripheral blood smear. Though they are small, they are highly complex and they contain a lot of things within them. They came from the biggest cell in the bone marrow, from the megakaryoblast um, that matures into megakaryocyte, and then eventually we have the small platelets that are set out into the peripheral blood. They don't have nucleus. They are disc-shaped. They have a size of about 1 to 4 micra, and their lifespan is 10 days. Okay, so speaking of the lifespan of platelets, in the laboratory, we have platelet concentrates that we give to patients needing it. We keep the platelets in the lab for almost the same number of days. We go beyond that, they will not become effective or viable anymore, so we cannot transfuse it to patients. So the role of platelets is to protect vascular wall integrity. They are actually involved in primary hemostasis, wherein a primary hemostatic plug or the platelet plug is formed, just like what you see in the schematic diagram. This is an actual peripheral blood smear that shows us numerous red blood cells, as you can see here. We have a single neutrophil, and the smallest cells or structures that we see here are the platelets. We see several of them. This is a summary of what I've been talking about a while ago. If there is an injury to the blood vessel, the endothelium will be disrupted and the collagen underneath will be exposed. This will lead to the adherence of platelet to the site of injury. And then after that, there's going to be activation of the platelets, which will lead to the release of the contents of their granules. The effect of this is to recruit other platelets to go to the site of injury. And then at the same time, there's going to be activation of coagulation factors in the pathway. And the end point of the coagulation pathway is thrombin formation that will now be a factor in the formation of fibrin, which will be part of the secondary hemostasis, forming a more stable hemostatic plug. So, how do we screen or test for platelet function? We have several ways of doing that. Number one is platelet counting. We'll be talking about this in a while. You can test, this is with regards to the number, and then for specific function of the platelet, we can check for aggregation, we can check for platelet retention, we can also determine the level of beta thromboglobulin and platelet factor 4. Take note that these two are within intact platelets. If there is an increase, turnover, or distraction of platelet, they will be released. So you will see an elevated amount of these two things. The fifth one is bleeding time. This can be easily done. There are several ways of doing this, and this is commonly requested. Okay, platelet count. Um, this laboratory examination is done using peripheral blood smear, or can make use of um, blood that is placed in a collecting tube using a machine to determine the platelet count. With regards to the use of peripheral blood smear, the stained peripheral blood smear, it is said to be the quickest, the simplest, but it is the least reliable if they are not made appropriately. As you can see, written here is the disadvantage of making a peripheral blood smear coming from a collecting tube because the platelets they tend to adhere on the side of the test tube. So how do we provide a solution for this? We must mix appropriately the blood in the test tube before making a peripheral blood smear. Or what we can do is to create a smear directly if you are collecting blood before putting the blood into a test tube. When do we say that platelet count is adequate or platelet estimate is adequate if you're looking at a smear? If you see one platelet per 20 red blood cells, or if you are looking at one oil immersion field and you see about 7 to 20 platelets, then that indicates that the number of platelet is adequate. Using machines or hematology analyzer, you can make use of electronic counting, and the preferred test tube here is the one with an anticoagulant of EDTA, no? Or if you're doing manual platelet counting, you can make use of an anticoagulant in the form of ammonium oxalate. The electronic counting is said to be subjected to error because if there are numerous white blood cells, or if there is severe red blood cell fragmentation, this can be perceived by the machine as platelets. So that's going to be an erroneous reading. The normal range is from 150 to 450,000 per UL, and we have an average count of 250,000 per UL. We can also test for specific function like platelet aggregation. We can measure that. This would assess the functional ability of the platelets to aggregate to form plugs. No? The setup would require plasma coming from the patient, of course, and we have commercially prepared known aggregation inducers like ADP, collagen, and the rest. And this one requires a machine known as aggregometers. When doing this test, patients are advised not to take any medication for a week that could affect the platelet function, like aspirin. This test should be performed within 3 hours upon collection. We are advised not to refrigerate the sample because refrigeration can inhibit the platelet function. In relation to this, as I mentioned a while ago, we have platelet concentrate in the blood bank to be transfused to patients. We are not storing it inside the refrigerator. We just keep it outside at room temperature, place in platelet shaker or aggregator, and they just stay there until these are taken into the ward to be transfused to patient. Sodium citrate is the anticoagulant that is used for this particular examination. And we should not be using glass tubes because glass tubes actually activates platelets. How do we interpret? If the aggregation occurs in 60% or more platelets, then it is said to be normal. Let's look at bleeding time. This is actually the best indicator of functional platelet deficiency. If the level falls to less than 100,000 per UL. And we can see that bleeding time is prolonged in the following conditions that are listed here. There are three techniques that we will be studying today. We have the Duke's technique, we have the IV, and the template with the corresponding um, normal values. The IV technique and template are almost the same or they are similar, no? Both of them will be using the volar aspect of the hand and applying constant pressure of 40 millimeter mercury. The IV technique, more or less, it creates a 3 millimeter deep incision, while the template it uses spring-loaded blade that would make the cut to have standard size and depth. No, so this is more reproducible compared to the IV technique. This is the setup. You apply beefy cuff and apply pressure on it, and then you create a wound. Okay, on the volar aspect, you need a filter paper. When doing bleeding time, um, you start timing the moment the blood comes out, and then for every 30-second interval, you blot the blood in a filter paper. Make sure that it will not be touching the skin of the patient, because the reason for this, you might dislodge the platelet plug that is being formed in the process. So after that, if there's no longer blot of blood that is being seen, then you count now the time, the length of time that bleeding has occurred. Duke's bleeding time, this one uses earlobe or fingertip. You pierce it with a lancet. This used to be the lancet that we use to do bleeding time. You can make use of fingers. Just make sure that um, the finger is free from callus or other problems that would hinder or affect the bleeding time. For smaller children or babies, you can make use of the earlobe. These are the new lancet that we use. It is more standard in a way when you create a wound using this. The next thing that we will be discussing is the coagulation protein system. This system serves to form thrombin, as I've mentioned early on, that will initiate the proteolysis of fibrinogen, leading to the formation of fibrin clot. So this is the same thing. This system converts the soluble plasma protein fibrinogen into an insoluble gel known as fibrin by the action of this enzyme, thrombin, and this will now establish the secondary hemostasis, the one that I was mentioning, that will form a more stable fibrin clot compared to the um, platelet hemostatic plug, the primary hemostatic plug. So listed here are the different coagulation factors. Okay, so we have a lot of them. This is an additional list of coagulation factors which are distributed in the coagulation cascade pathways. On this side, on the left side is the intrinsic pathway, and then we have the extrinsic pathway on the right side, and they converge to the common coagulation pathway. The intrinsic starts with factor 12, while extrinsic starts with factor 7, and this one will end into this one, formation of fibrin. So, facts about coagulation factors. It says here that all coagulation factors are produced in the liver with certain exemptions. Factor 3 are formed in the tissues. Factor 8, aside from liver endothelial cells, they also come from megakaryocytes. Then we have the von Willebrand factors, which are produced in the endothelial cells that line the blood vessels. Then we have factor 13, which are produced in the liver or the platelets. Additional facts: all factors are present in normal fresh plasma. However, factor 5 and factor 8 are not stable. The rest are stable. So, after a while, after collecting blood and storing it, the blood will lose these factors, factor 5 and factor 8. So, bear that in mind when you are thinking about um, stored blood. Tests of coagulation system are the following. We have the oldest Lee white clotting time. Then we also have activated coagulation time. The ones in red font, the PTT or activated partial thromboplastin time, prothrombin time, and thrombin time or thrombin clotting time are the commonly requested coagulation system laboratory examination. We can also make use of fibrinogen measurement as well as detection of fibrinopeptides and fibrin monomer. A little bit of discussion on the Lee-White clotting time. This is said to be the oldest and the least accurate test of coagulation. They make use of three test tubes incubated at 37 degrees centigrade. Each tube will be containing 1 ml of blood, and these are tilted gently at 30-second intervals until clotting is observed. The normal value or range of time for this to happen is about 4 to 8 minutes. This is said to be extremely insensitive, and the role of this is to monitor heparin therapy previously. Now we have the activated coagulation time. This one also monitors heparin therapy. However, this is utilized in extracorporeal circulation, just like in cases where patients are undergoing bypass procedure, hemodialysis, or hemopheresis. So the whole blood is collected into tube with cellite or clay, and the normal value is less than 100 seconds. PTT, partial thromboplastin time, we make use of citrate as anticoagulant. Um, this is the time taken for a clot to form, and the normal value for activated PTT is 28 to 40 seconds. Take note that this examination assesses the intrinsic and the common pathways. So, on the other hand, we have the prothrombin time. This is the examination that is most frequently performed with regards to coagulation testing. The normal PT result is about 11 to 13 seconds, or it should be within 2 seconds of the control. This time, it assesses extrinsic pathway as well as common pathway. When we request for prothrombin time, you will also be given international normalized ratio or the INR. This is the ratio between the PT of the patient and the PT of the control mean. It is used to standardize anticoagulant intensity. Okay, so you make use of this to weigh whether you're gonna add more or decrease uh, your your oral anticoagulant being given to your patient, and there are recommended INRs for the different conditions as we can see in this table. So we're almost the same. No, if you have a patient who had acute MI and you want to prevent recurrent myocardial infarction, you should maintain the INR at 2.5 to 3.5. The same thing holds true for the rest of the conditions listed here. So, how do we interpret? If PT is prolonged and PTT is normal, Most probably the problem is in the extrinsic pathway. So there might be some factor 7 deficiency. There are certain cases, although rare compared to the extrinsic pathway problem or deficiency of common pathway factors as listed here, or it can be due to liver disease or warfarin intake or medication for patients. PT, what if PT is normal and PTT is prolonged? Of course, you would think more of the intrinsic pathway. There might be a condition that is associated with bleeding, and the following factors are the ones that are defective. If it is not associated with bleeding, these factors now are the ones that are involved. What if both PT and PDT are prolonged? There are a lot of medical conditions that are associated with this. No? It can be the giving of anticoagulants, could be disseminated intravascular coagulation or certain liver diseases, even vitamin K deficiency. Massive transfusion can also give this picture in certain rare dysfibrinogenemias. There are also certain cases wherein PT and PTT are normal. Like for example, in factor 13 deficiency, they don't affect um, the level of PT and PTT. Thrombin time, on the other hand, we make use of citrate. No, this is the time taken for saturated blood to clot after calcium. The known amount of thrombin is added. Okay, so this is a direct measure of fibrinogen function. So this is expected to be prolonged if you have low levels of fibrinogen, like in hypofibrinogemia, or dysfunctional fibrinogen in dysfibrinogenemia. The normal value is 10 to 15 seconds, or it should be within 1.3 times as long as the control. Next system is the fibrinolytic system. You don't want a blood clot to stay within the vascular channel forever. We have to have that clot lysed to reestablish the normal flow of blood in the vascular channel, and fibrinolytic system is the one responsible for that. So in here we have several factors. We have the tissue plasminogen activator, the TPA. We also have the urokinase plasminogen activator. Um, Example, we have the scupa and the tecupa. All this will convert plasminogen to plasmin. Okay, so the role of fibrinolytic system is to digest fibrin, which was formerly made in the coagulation pathway when it is acted upon by plasmin. This plasmin will convert pyrene into small fragments or otherwise known as fibrine degradation products or FDPs. So this is a schematic diagram that summarizes what I have been talking about a while ago. We have here the plasminogen, which is acted upon by these different activators, converting it into plasmin, and now the plasmin will act on fibrine, which will now be degraded into smaller fragments, which we call the FDPs or the fibrine degradation products. So this is the same thing. It's a little bit colorful than the first one. So we have here the clot or the fibrine clot, which is a product of secondary hemostasis. We have the plasminogen acted upon by these factors. The plasminogen will be converted to plasmin, which will now act on this fibrine clot and degrade this into smaller fragments. So how do we check on the fibrinolytic pathway? We can do fibrinogen degradation product determination. We can also do D-dimer assay. D-dimer are also FDPs. They are found in more than 90% of patients with thrombotic and thromboembolic disorders. We can make use of euglobulin lysis time that will take about 2 to 6 hours, and because of the length of time, this is very rarely used. Other tests are the following that will check on the fibrinolytic system. Now we go to the next system, the anticoagulation protein system, or the natural anticoagulant system. This one regulates all enzymes of the coagulation and the fibrinolytic system to make sure or to see to it that there is no inappropriate excess of either clotting or bleeding that would occur. So we have here the different factors that are found in the coagulation protein system. We have the protein C or protein S system. We have the plasma serine protease inhibitor system, or otherwise known as antithrombin. We also have the tissue factor pathway inhibitor. This is where you get to see these different structures or substances or factors in the coagulation cascade exerting their effects or function in these different areas of the coagulation cascade. Okay, so we're done with the discussion of the normal process of hemostasis. So before we talk about the different disorders associated with this, um, let's just summarize that we have talked about the platelets. The platelets, which are said to be involved in primary hemostasis, forming the not so stable uh, primary platelet plug. We also talk about endothelium, wherein disruption of endothelium that lines the vascular channel will expose the collagen, and this will now um, affect or stimulate the platelets to adhere to the site of injury, leading to, of course, adherence or adhesion, aggregation, platelet release reaction. Okay, and at the same time, there's going to be stimulation of the coagulation pathway, the endpoint of which is the formation of the more stable clot with the production of fibrin. Then we have the um, fibrinolytic system that will try to degrade the fibrin clot that was formed in the coagulation system. And then we also have the natural anticoagulant system that will make sure that there is no excessive bleeding nor clotting will occur inside the body of the patient. Okay, so we're done with that. We will now go to the discussion of the different um, pathology in relation to this different system or different structures that we have previously discussed. Let's look at the platelet disorders. Platelet disorders can be quantitative, can also be qualitative in the sense that um, there is a problem in the function of platelets. Okay, so quantitative, it can be decrease in number, which we call thrombocytopenia, or it could be an increase in the number of platelets, which we call thrombocytosis. Um, Platelet dysfunctions, no, or disorders can be inherited or acquired, as stated here. So thrombocytopenia, if you will compare the count, no, of a normal person compared to a person with thrombocytopenia, you will observe that there is lesser number of platelets seen in the peripheral blood. So thrombocytopenia is a decrease in platelet. It can be caused by a lot of things as listed here. So these are actual slides, no? Now showing us thrombocytosis. So the one on your left is the smear that contains normal number of platelets, although they are seen in aggregates. And on the other side, you get to see numerous platelets. The small structures here are all platelets, and this is a condition known as thrombocytosis. Thrombocytosis is the increase in platelet count. It could be a benign process if the count is not more than 1,000 times by 10 to the 9 per liter. But if you go beyond that, you might be dealing with a myeloproliferative process or disorder that might be malignant. Okay, so these are the different inherited disorders of platelet function, no? Platelet function in the sense na there is a problem in adhesion or aggregation or even the platelet secretion and transduction, or it can be a defect in cytoskeletal regulation as well as a disorder of platelet procoagulant activities. With regards to adhesion, we have a specific example, the Bernard-Soulier and certain abnormalities of glycoprotein 1A, 2A, and 6. Von Willebrand disease is also a disorder of platelet adhesion. So there are three types of von Willebrand disease, types 1, 2, and 3. If there is partial quantitative deficiency, that's type 1. Complete deficiency is type 3. Type 2 is qualitative deficiency, and this is further divided into 4 subclassifications. An example of disorder of platelet aggregation is Glanzmann thrombasthenia. So as you can see in the diagram, comparing it with normal, wherein you get to observe appropriate aggregation. With Glanzmann, that's the problem, the aggregation of platelets together. There are also examples of disorders of platelet secretion and signal transduction as listed here. Specifically, it might be a deficiency in granule stores or specific platelet signal transduction defect. This slide shows us examples of condition wherein there is cytoskeletal regulation problem in Wiskott-Aldrich syndrome, and SCAT syndrome is a disorder of platelet procoagulant activities. There are also acquired disorders of platelet function like the myeloproliferative disorders, certain leukemias, myelodysplastic syndromes, and dysproteinemias. These are um, examples of acquired disorders of platelet function. So we have here the uremia. They are actually associated with other disease condition or pathology. No? Included here also are the effects of certain medications, certain drugs that inhibit platelet function, just like aspirin and NSAIDs. This is a picture of um, a child manifesting with a platelet problem. It could be a manifestation of small hemorrhages, just like this one, petechial hemorrhages, or the manifestation can be larger areas of hemorrhage, like ecchymosis, hematomas, like this one. Okay. We also encounter coagulation disorder. So this is now involving the coagulation pathways. There are certain hereditary coagulation protein defects like the hemophilias, certain deficiencies of other coagulation factors, or it can be an acquired coagulation protein deficiency, just like the ones listed here. We already mentioned about DIC, liver disease, of course, because the liver produces majority of coagulation factors, certain factors that are affected by vitamin K deficiency, factors that are depleted because you're giving a massive transfusion of purely packed red blood cells, and as well as acute coagulation protein inhibitors. Let's talk about hemophilia. Hemophilia is an X-linked disease or condition. There is lifelong tendency for patient to have excessive bleeding, and this is seen exclusive in almost exclusive in men. Mm. We have two types. We have the hemophilia A, which is known as the classic hemophilia. We have the Christmas disease, the hemophilia B. Specifically for A, factor 8 is the deficient factor, and factor 9 is the deficient factor in Christmas disease. Take note that hemophilia A is more common than hemophilia B. What are the manifestations? Of course, bleeding, okay, but and later on, no, there might be a sequelae of joint deformities secondary to on and off bleeding, um, inflammatory process, and then eventually it can affect the joints leading to deformities. So this is a schematic diagram that shows us the manifestations or the symptoms that are observed in hemophilic patients. So this is the one that I was mentioning a while ago, joint deformity secondary to hemophilia. There are also deficiencies of other coagulation factors. Now, these are rare except for factor 11 deficiency, and these are manifesting with mild bleeding. DIC, on the other hand, disseminated intravascular coagulation. There is combined activation of both the coagulation and the fibrinolytic system. So this condition, leads to formation of thrombin as well as plasmin. They also call it consumptive coagulopathy, no? Because it consumes or there is consumption of coagulation factors and inhibitor. Patient will be noted to have prolonged PT and PTT. They also have thrombocytopenia because the platelets are being consumed, and the related or disorders are the following. You can observe this in a lot of conditions like sepsis, which is more commonly this one, in certain malignancies as well, OB complications, and massive tissue injury. Patient can have DIC or disseminated intravascular coagulation. Liver disease, since this is producing most of the coagulation factor, you would observe that there is prolongation of PT and PTT. Um, the reason behind there is decreased protein synthesis, and if ever there is normal amount of protein being produced, but those proteins are structurally abnormal or functionally abnormal. Vitamin K deficiency. So this is seen in very ill patients who are given parenteral nutrition. This is also observed in alcoholics, and this would affect the following factors. Of course, we know about 2, 7, 9, and 10. Let's add protein C, S, and Z. Massive transfusion, on the other hand, no, particularly if you are replacing more than 1.5 liters of blood volume, within 24 hours. No? You would observe that there is prolongation of PT and PTT. Okay, so in here we can observe decreased fibrinogen as well as thrombocytopenia. So take note of that. That when you are giving massive transfusion, you must be aware that your patient might be needing additional fibrinogen and platelets um, to help them with the blood loss. So there are certain acquired coagulation protein inhibitors. Can be against factor 8, which is most common and severe. Amyloidosis. This is associated with acquired deficiencies of factors 10 and 11. We have multiple myeloma and Waldenstrom macroglobulinemia, also lupus anticoagulant and APS, antiphospholipid antibodies. Okay, so this one shows us the thrombophilic proteins or factor problems associated with increased risk for thrombosis. Uh, so if there is deficiency of antithrombin, protein C and S, then there is a tendency for or a risk for thrombosis or thrombus formation. There are also acquired hypercoagulable states in the form of APS or antiphospholipid syndrome and lupus anticoagulant. APS is associated with um, recurrent or, repeated abortion because of several factors that leads to hypercoagulable state, making it difficult for the baby to implant into the uterus of the mother. Similar condition, we have the lupus anticoagulant. You can segregate this from antiphospholipid by doing certain specific laboratory examination. And lastly, we have the hyperhomocystinemia, which is also associated with hypercoagulable state. Um, this has genetic involvement. Okay, so these two are or three are the reasons for acquired hypercoagulable states. So that's it. Thank you for listening.